Alright, so here we are with the tests, and they're organized in three different ways. The sensitivity, specificities, the predictive values, and then down here, the likelihood ratios. And the way to think about this, similar to the previous one with the phases, is that they each answer questions that the other ones don't. And let's start with the one that everyone has to know, sensitivity and specificity. The easiest way to think about sensitivity is no means no, and specificity as yes means yes. So sensitivity and specificity are both properties of a test. They don't vary with the population. All right? A sensitive test, again, no means no, means that when you have a negative on your test, the person doesn't have it. At least that's the case with a very sensitive test. If you don't have a sensitive test at all, if it's not sensitive, like if the sensitivity is 10% or something, then in that case you can't guarantee that a negative means they don't have the condition. And similarly for a specific test, yes means yes. A positive means that they do have the condition. And you can go and look at the equation and see why this is. Well, why is sensitivity no means no? Well, because you're minimizing the false negatives. Meaning there is no false negatives. Meaning every no is true. Same thing with specificity. There are no false positives. Every yes is true. At least theoretically. Alright, so when do you use a sensitive test? When do you use a specific test? Well, a sensitive test is good for screening just in general. If someone has coronavirus or something, or you're wondering, hey, how many people here have coronavirus? You just give them a bunch of tests and you say, well, look at this super sensitive test. It says Bob doesn't have it, so okay, he's good. All right. So specific test is when you want to really, really, really narrow something down. All right. A good example is if you're doing rheumatology or something and you want to see if someone has, lupus. All right. So you always learn, well, you don't do the ANA test, you do the anti-double-stranded DNA test or antihistone if it depends. But the idea is that double-stranded DNA is a much more specific test than the ANA test. Meaning, if it comes up yes, odds are really good that you have lupus. Okay. But like I was saying before, specificity and sensitivity, they're both properties of a test. They don't change with the population. All right, but people started having, problems with this, because you would take a test and you would give it to a person and it would say positive or it would say negative. And clinicians would then have to say, well, damn, does it mean they actually have it? And for this, you have predictive values. All right, so predictive value tells you, if I have a positive test, how likely am I to actually have it? Or if I have a negative test, how likely am I to actually have it? So it's actually different from sensitivity and specificity because it has to do with the population. In fact, I like to think of the predictive values as population values. And you'll see in the next slide or whatever how with a positive predictive value, this is going to be better in a population that has something or where a certain condition is very prevalent. And a negative predictive value is going to be stronger in a population where that thing isn't really present so much. Let's actually take a look at that. So here we have two populations. They both have 1,000 people in them, all right? So in the first population, you'll see that there's a lot of people who don't have a disease. In the second population, you see that there's a lot of people who do have a disease. Okay? So how does that affect everything? Well, let's go down really quickly and just make sure we got this right. Sensitivity is the same, specificity is the same in both of them. You can actually do the math. All right. But in case number one, we have 100 people who have the disease, all right? 90 and 10. And you have 1,000 people who don't. So you have a total of 1,100 people. Well, the positive predictive value, meaning, when this thing comes up positive, what are the odds to actually have it? It's kind of a coin flip here. 0.47. Sometimes yes, sometimes no. Whereas here the negative predictive value means a negative test is, super certain that this person doesn't have it. Conversely here, where a bunch of people in this population have it, the positive predictive value of a positive test is off the charts. And the negative predictive value is not so great. So what do we really learn from this? We learn that if you're in a place where there's a lot of people with the condition and you test positive for that condition, the odds are, here you go, 0.99 or 99% that you have it. Conversely, if you're in a place where no one really has something and you test positive for it, it doesn't really mean that you have it, even if the sensitivity and specificity is really good. However, if you test negative for it, odds are you don't have it. So where does this come into play? Well, let's say that you're testing for malaria or something, right? So malaria, we know it's common in places like India or sub-Saharan Africa or warmer regions. So let's say you're in Point Barrow, Alaska, and you're being tested for malaria. And the test, which is a sensitive and specific test here, this test says, oh yeah, you got it. No one really has it. No one really has it in Alaska. Point Barrow, Alaska, of all places. So, it's not really, significant in the same way that a negative test is. The negative test in Point Barrow, Alaska, you can bet your bottom dollar that it's actually negative. However, if we were to do this, let's say, in India or someplace where it's much more prevalent, you get a positive, well, you can be pretty certain that you actually have it. Whereas the negative, you can't really be certain because it's kind of a coin toss. Okay, so how do you use this to look at data, Well, you can look at studies, you can say, well, hey, this one journal article I read was talking about how, people with strokes and stuff had to do, X, Y, and Z when they were inpatient. And so, therefore, 25-year-old healthy males should do the same thing. Well, not really, because the population's different. One of them are inpatient stroke survivors, and the other one are just healthy young men, You can't really generalize this because it's two different populations. So as we can kind of see here, the problem and the advantage, I guess, depending on how you look at it, with predictive values, or as I call them, population values, is the population. How can I make this, generalized to a whole bunch of people? And that's where likelihood ratios come in. So let's kind of go down here. We'll get to this thing right here. We'll get to the thresholds in a few minutes. Let's get on the likelihood ratios. Likelihood ratios are telling you how likely is this result to be, in someone with the disease compared to someone without the disease. Okay, and likelihood ratios aren't affected by the population that you're in the same way that predictive values are, which we saw. So just to think about likelihood ratios, you have two different types. You have a positive likelihood ratio and a negative likelihood ratio. Positive likelihood ratio, it's a ratio, so it's comparing, how likely is this result how likely is this to be tested positive in someone with the disease compared to a normal person in the population? Well, you want that to be super high. You want your ratio of positive tests in positive people to be, damn near 100%. And you want your positive tests in normal people to be as close to zero as possible. So when you end up doing that, the numerator here gets super high. The denominator here gets super low. And it actually has more to do with the denominator. It has more to do with specificity. All right? It's one of those, again, yes means yes. And we can actually see why. Because as specificity gets closer and closer to 1, the denominator gets closer and closer to 0. And of course, anything except 0 divided by 0 blows up to, gigantic numbers. So again, a positive likelihood ratio is telling you, the ratio of, how can I expect this test to be positive in someone who has it compared to positive in a normal person who doesn't have it. And you want those ratios to be super high in the first case, super low in the second case, giving you a small denominator and blowing up the numerator, or blowing up the total value. Okay. Another way of thinking about it is you can think of positive likelihood ratios as having a lot to do with the specificity. Because again, here, the value of your likelihood ratio is going to be more dependent on having a high specificity. So if you have a low false positive rate, which is indicative of having a high specificity, because again, yes means yes, so no false yeses, meaning this denominator here goes close to 0, your entire fraction is going to go super high. Okay, let's look at negative likelihood ratios. Well, in negative likelihood ratios, it's saying how likely is this test result to be negative in someone who has it compared to a normal person in the population. Well, you don't really want your test result to be negative in someone who has it. So you want that to be, you know, super low. You want that numerator to be damn close to 0. All right. And again, you can think of this as the false negative rate, or you can think of it as having to do with sensitivity, because no false negatives. If you have a low false negative rate, your numerator falls to 0, and then 0 divided by anything, you know, except for 0, of course, where you do your calculus and it gets a bit weird there. But 0 divided by most things is going to end up being 0. So you want a very high likelihood ratio for positive and a very low negative likelihood ratio, because again, it's telling you what are the odds of this test result being positive or negative in someone who has it compared to the normal population. All right, so here's the third thing here. The true negative, true positives, false negative, false positives, and then shifting thresholds and cutoff values and stuff. This is something that you actually see a lot, not just in step 1, but the way that they're going to ask you these questions isn't going to be by showing you this. So when you see these kinds of questions, it's easy to get into the trap of saying, you know, oh, look, this curve's shifting to the right, or it's shifting to the left, and here it's shifting to the right, so cutoff value for whatever is going to increase, and more false negatives, sensitivity is going to become more problematic, or, oh, they said, you know, decrease the cutoff value, so this means more false positives, and, you know, that means the specificity is going to get worse at the expense of sensitivity, blah, blah, blah. But if you just think about it in terms of arrows, you're going to get screwed on the test, because everyone can read arrows, including 5-year-old children. And that's not really what they're testing you on. Can you understand left and right? They're going to give you like 2-jump or 3-jump questions, more akin to something like, hey, if it's harder to get a positive score, what's going to happen to the sensitivity? And then if you've just been relying on your left and right arrows, you're going to be in a bit of a pickle, and maybe it'll take you 30 extra seconds that you could have used on a cardiology question, where this is more straightforward if you already have a good conceptual understanding of everything. So let's think about that. So if it's harder to get a positive score on the test, you know, no one's saying anything about thresholds, no one's saying anything about cutoffs in this question specifically. But you can imagine if it's harder to get a positive score, you're going to have a decrease in the amount of, you know, your positives at an expense of some negatives that might not actually be negative. You know, you're going to have fewer positives, fewer false positives in general, but at the expense, of course, because it's a zero-sum game, of having an increase in false negatives. So what will happen to your sensitivity now, because you have an increase in false negatives, is that you're going to have a decrease in your sensitivity. And that's kind of how you want to think about it. You know, that was like a 2-jump question, but that was a pretty easy one. They'll likely just have you like read a block of text or something, and then you have to like infer kind of this setup here. And what's important here to understand is also that on the test, they're not going to give you these double peaks. Okay, like that's something that you have to already like think about and understand in your mind. So that way, when they do say, oh, you know, sensitivity is going to get screwed, you can already think of, oh, that means, we're going to have more false negatives, and that's kind of how you would think about it more conceptually than just in terms of arrows moving left and right, because that won't get you anywhere.